Coming up today on Inside the FLX, discussing swing beds and what they mean for patients who have a stay at an area hospital. This episode is brought to you by DeSanto Propane. They've been serving the clean energy needs of upstate New York homeowners, businesses, and home builders since 1937. With a reputation of reliability and dependability, DeSanto Propane is ready to serve you. Call 1-800-752-4574 or visit DeSantoPropane.com to learn more. And by the Fox family of dealerships located on Route 5 in Auburn. It's all there and all together at the Fox family of dealerships. Visit foxdealerships.com to learn more. Today on Inside the FLX, we are discussing swing beds. Despite what the name suggests, swing beds aren't a physical bed in the way that most would anticipate. Swing beds, or the swing bed program at Finger Lakes Health, was developed to provide patients with care following hospitalization. It gives them time to recover from surgery or illness and transition to life at home or wherever comes next. To discuss the swing bed program at Finger Lakes Health, we have Maureen Loyal and Katie Dimitri in studio with us. Loyal serves as Director of Rehabilitation, and Dimitri is a nurse manager of the Acute Care Unit at Soldiers and Sailors Hospital in Penn Yan. We pick up the conversation looking at the fundamentals of the swing bed program.
The swing bed program is a short-term rehab program at Soldiers and Sailors Memorial Hospital. And since that's a critical access hospital, it allows us to have a short-term rehab program there where a typical standard hospital bed where someone would come in and if they were acutely ill, stay, that bed can be swung into a rehab bed. So this way it has a dual purpose for it.
And how important is having that flexibility built into facilities like those in Penn Yan and around that area? When you are talking about, we were talking a little bit earlier about, before we came on, how rural facilities are needing to do more of this. It's actually pretty common, right?
Yes. Centers for Medicare Services, CMS, allows the swing bed program to help keep those rural hospitals strong in the community. So it's a very viable option for them to provide a service to rehab patients and keep them in the community and get them home independently, but also at a rate that can help keep the hospital strong and be able to provide those other services like the emergency room and the hospital setting floor.
Is this the kind of program that if it didn't exist, you think probably broadly across the country you'd see more hospitals downsizing or changing the way they operate fundamentally?
Yeah, you can even might even lose the hospital in the community if they don't have these programs.
Mm-hmm. Okay, so I want to switch gears a little bit. What are the actual components of swing bed care? So somebody is a candidate for it, and what does the process actually look like for them as an individual when they are at the hospital and then they transition into the swing bed program?
So you can be a patient in our hospital at Soldiers and Sailors Memorial Hospital, or you can be a patient at any hospital in the area looking for a short-term rehab. So if you have to have a 3-day hospital stay. We get a lot of patients who are weakened from a prolonged hospitalization, if they had a joint replacement, if they had hip fracture, or if they had a stroke. So those are all candidates that are in a hospital setting that they're not well enough to go home and they need that service in between. So what happens then is the care management departments at the facilities will work with you and provide that option that if you live in that area or you live anywhere near that area, that rehab bed is there for you. And once you come to our hospital, there's a bunch of different programs that we offer while you're there for short-term rehab. I am responsible for the physical therapy, occupational therapy, and speech services that you might need. So our therapist will look at you and figure out the more global needs. How many stairs do you have to get into your house, within your home, as well as what your bathroom may look like. Do you have a shower stall or a tub, so that we can make sure that you can take care of your activities of daily living. Speech, if you have cognitive issues, to see if we can get you back able to balance your checkbooks and look at different things that help you survive in life outside the hospital. So we develop a program specific to those things, but then we also look more at the individual and try to tailor it to them. So we've had patients who primary goal is to walk their daughter down the aisle, so then we make it more specific to the patient, or they want to get back to golfing, or they want to garden. So we'll try to, towards the end, when we get them more independent, doing those stairs and those more global things, we then fine tune it to get them back to their lives and doing the things that they really care about.
And it's interesting because how long has the program existed or been in action with Finger Lakes Health?
Since we have the rehab beds at Living Center South and North in Geneva and Huntington Living Center in Waterloo, as well as the Homestead, the primary focus has been on that. But now with the different changes in healthcare, the swing bed program has always kind of been there and been an option for folks, but now we're trying to really highlight it, just really to keep that Soldiers and Sailors Memorial Hospital strong in the community. So it's been around for a few years, but in the last 3 or 4 years, our volume's grown. We've really had great successes with patients to get them back home, working with Katie's nursing staff on different issues. It's been really fun to see it grow and become more viable for that building.
And Katie, I want to shift gears to you. How do the nurses feel about a program like this that provides a little more flexibility for you guys to be able to sort of evaluate case-by-case situations rather than sort of have X, Y, and Z protocols and without the latitude to move freely?
So being that we're a critical access hospital, we have generally a shorter length of stay, around 3 or 4 days. So when we have this population integrated into our acute census, it allows for them to, again, cater the plan, the work plans, the daily activities, and kind of how they structure their day at home. We try to mimic that there as well, and they get to grow friendships and things like that with the patient because we have them for a longer period of time.
And I guess that's probably one of my personal curiosities is what is the reception like this typically for the patient? How do they feel about having this sort of flexible environment for them to go into and then really be helped in that process of transitioning from hospital care to whatever might come next, whether that's living at home or longer term rehabilitation?
It really helps. It's a little different because now they get dressed, they wear their own clothes, so they feel that they're one step closer to home. It's always a positive atmosphere, rehab sites, because they're going to get them home. They know that's the ultimate goal. So to see the patients really transition and work well, Katie's also on her staff has our activities coordinator who will take the patients down when they're not in therapy services and try and do things if they like crosswords or crocheting, and so it just makes them feel human again, because sometimes you lose that on that hospital side of it, right? Because you don't have your own schedule. They're coming in all different hours, taking your blood work, and you're ill. Now you're better, and that you're closer to being home.
And psychologically, I would assume for the patients and for you guys, Katie, it probably helps them feel like they're making more progress, making it more tangible progress, and maybe inspires them to work a little harder and maybe try to be moving forward as quickly as they personally can, right?
Certainly. They to have that goal of going home helps to motivate them for sure.
And living in Penn Yan, homes are a little bit different, right? They're a little more rural, so they have different makeups, and so when they get closer to home and become more independent, there's also the opportunity for our therapy team and the nursing team to go out to visit their home and bring the patient there to test drive the first run through the house to make sure, make any modifications just to make it a smidge safer for them when they do get home. So that's always an option to help. They got that team that helps them make that bridge back into the community.
And are there ever any scenarios where a patient might know prior to going in for an operation or something to that effect that they may be involved in a program like this after the fact? Or is this something that's generally the decision is sort of judged and made after procedures are done and things like that, and they're in sort of a recovery process already?
Most of the time it's after, because it's an unplanned event if you fracture your hip or if you have a pneumonia that brings you into the hospital that has you there longer than you thought, so you got a little bit weaker if you were older. But the elective person if you chose to have your knee replaced or your hip replaced, there's always a class at Geneva General for our joint center that's prior to the surgery, so that's an option where you can start to discuss that with the care management team, with the nursing team over there about options afterwards. So that's when you can plan it if you have a planned joint replacement.
And it's got to be great for not only patients themselves, but I would assume family members of patients too, who probably feel a lot more comfortable going through a process like this, knowing that a bit of a transition effort is actually happening at the hospital prior to them just being wheeled out and being home.
It's a scary situation a lot of times, and sometimes it's the first time that they've ever had an encounter with healthcare, a lot of these folks. And so to have that support team around them within the hospital and know that there's a bridge and that there's someone that their family can speak to about the different options, can be really give them peace of mind.
For you guys, and I want to throw this one to both of you, bring both of your perspectives to the table. What are some of the challenges that come along with administering a program like this and sort of being involved in these day-to-day real-time decisions that have to be made along the way?
For us in therapy world, I know is that sometimes the expectations can't meet the disability, so that they may not get back to where the full independence, a modified independence, or actually still needing some assistance when they leave us, and the expectations of the family and the patient might exceed where we're able to get them. Or some of the other challenges is too that they think, like somebody will come and I always say as a therapist, we give you the roadmap, you have to do the driving. So to get them motivated enough to know that ultimately the ball's in their hands, and they have to be able to follow that program and participate fully in that program. It's not passive, it's an active program to get them back to that. So being able to reach their goals is one thing, because sometimes we can't. But we work with you, that's the whole psychological component, saying, okay, we might not be able to get you here, but we can get you here, and afterwards, there's continued therapy, whether it's comes to your home or you get to an outpatient site that maybe be able to get you to that full goal. So those are some of the challenges that we see in the therapy world.
And on the nursing side, I would assume sort of the unpredictability of it all is probably one of the bigger challenges that you guys face. But just in general, talk to us a little bit about how you guys handle that and how you sort of approach the day-to-day of maybe not knowing what the levels are going to look like on a Wednesday versus 48 hours later on a Friday.
Sure. So I'll kind of walk you through, like when they get there as a swing, we generally do a meet and greet where upon arrival we go in with as many team members as we can, get at that time, introduce ourselves. And then really once they start to start their therapy sessions, we kind of get an idea of where they're at with things. And then each Tuesday we have a meeting with the team. So it's Maureen, myself, our activities coordinator, the physical therapist, the occupational therapist, and the care manager. And we kind of touch base and forecast where we anticipate this patient to be in a week, in a few days. And then we have meetings with not only the patients but the families as well. If we start to see that there's participation issues, or we're thinking maybe they're going to need some modifications to be made at the home prior to going home, we try to do all of that in advance so that nothing is sprung on them, and we really track it out so that it's a safe transition to home.
When are you, or how do you know when a patient is finished or when they've reached the point where you can, and obviously it's probably a case-by-case decision-making process, but generally speaking, is there a set of goals that you guys generally set with all patients that you want to see them meet before they exit the program and are back home living their normal life or whatever their new normal is?
Basically, our ultimate goal is to get them as independent as we can. And when we look at that usually starts with how safe are they going to be with home? If we, we won't discharge unless they're going to be completely safe at home. So that's the minimal criteria. And then ultimately, like I said, the goal is to be able to have them be able to walk in the community, which usually they say 1,500 feet is what one community activity distance is. So you have to be able to walk that 1,500 feet. And most people who are 65 and older, which is a large part of our population, do 3 activities in the community. So to get home, we want to get them over that 1,500 feet be able to do one thing safely, so follow up with doctor's appointments and the like. But ultimately, we want to get them to that 3 to 4 level, so 4,500 feet, to be able to go to CVS or Walgreens and get to their doctor's appointment and then go visit family. So, those types of measurements, we have a standardized test that we look at, this test called the Bartel, that kind of rates them on their independence with toileting, dressing, walking, and so that we try to see if there's a functional change on those scores from when they get admitted until they go home. And that length of stay could vary. Some people just need a minor tune-up, what we call it.
Yeah.
They were just in the hospital for a couple extra days after having a bout with pneumonia, so about a week and a half, they should be strong enough to get back to their prior level. And then other folks who might have more of a major event like a joint replacement or a stroke, well, they could stay, up to 20 days or more, just making sure that they're safe.
And it's interesting because to the layperson like me, that sounds like an incredible hurdle to have for patients to be making. But that's actually remarkable progress for a person to make in such a short amount of time, even if it is 20 days or something to that effect. How sort of impressive is it seeing patient after patient after patient successfully navigate that process and then go back to their lives, what they were doing prior to hospitalization?
I think Katie and I both say that that's why we went into the profession, right, to help people and to see that magic. We've had people come to us who couldn't even stand on their 2 feet yet, they were that weak, and leave us walking, or physicians sometimes tell them, I don't know if you'll ever be independent again, and they come to us, and we tailor the program. When you first come to us, if you can only tolerate half an hour therapy a day, that's where you'll start, and then we get people up to 45 minutes to an hour to sometimes 2 a day based on what your need is, and an hour therapy for PT, an hour of OT to get you moving. So it's a really amazing process to see people, the family members, their reactions too, because they're going through this, they're frightened, and to see the progress and have that joy come out of it, it's a really great experience.
And of course, we've seen the data for several years now. Folks are staying in their homes longer. Seniors are staying in their homes longer, and it means programs like what you guys are doing at Finger Lakes Health are really pretty important in terms of being able to maintain success in that arena. When you look forward and when you guys sort of plan, what are some of the goals that you set in terms of being able to continue providing not only the current level of support, but to be able to keep growing that support and increasing it so that there is more awareness about it? Because like you said, when we started, not everybody knows that a program like this even exists, maybe until they're actually faced with a situation where they're in the hospital themselves. So how do you guys sort of approach the raising awareness, educating people, and letting people know that it's not just if you go to the hospital for an illness or for a surgery, it's not just you're there for 3 days and then you're sent back home, whether you can function or not?
I'd say we're really trying to amp that up currently with doing some different radio shows to get the PR out there. Our team has recently gotten down to be on a couple of billboards. We rely on a lot of the care management departments to have the knowledge of our program and what we can do. So it's not only PT and OT, but it's those other skilled needs like long-term IV antibiotics, things like wound vacs that need to be changed more frequently than what visiting nurse can do at home. So anybody that would qualify in any of like those 3 departments, them knowing, hey, we do have a program. Additionally, the primary care offices in the area, because you don't have to go right from the hospital. If you've had a 3-day stay in the last 30 days, let's say they've discharged you and you go back to your follow-up appointment and they determine like, oh, I think that you need a little extra help. Yeah. If they have knowledge of our program, they can reach out to our care managers and we can still integrate them and bring them in.
Okay, well, that's interesting. Are there any success stories that you guys think about as when you're going through the day-to-day that really make you say, this is why we're doing this? You just hinted at it a little bit, Maureen, but when you see new patients come in, no matter how well or how many challenges they have in front of them, how do you keep the success stories in the front of your mind so that you're staying engaged in the process, because clearly it's one that's proven and one that works?
Well, I'm going to throw this to Katie in a second. There was a patient once, like I said, it's different levels of ability, right, that come into us. And some people were independent in the community prior to coming to us that we have to get them back to being independent, but some folks come in at other levels that they were wheelchair bound most of their life, and they had an illness that had them in prolonged bed rest and a lot of wounds that the nursing staff had to take care of. And there was one patient in particular that the mother was ecstatic. You know, we didn't get them back walking. They weren't a walker to begin with, but the care that Katie's nursing staff gave them, and he was there for a while and became a real part of the family, and just to see his outcome and how well he progressed in that, and he was quiet when he first got there, and how engaged he got with the whole team. He was sitting in on Katie's staff meetings, I think, by the end.
Yep, for sure. Yeah, that was definitely an experience that we keep close to our heart. And even the one going back to the one you were referring to before, where they came as a full lift, meaning they couldn't walk, and by the time this patient was discharged, he was walking, and happened to come in a year and a half later for a second, if you will, injury, and he was coming through the doors of the emergency room telling them, well, I'm going to swing bed when I'm done. You know, so he had already experienced a program and couldn't wait to get back. So that, you know, speaks volumes to, you know, the good that we can bring to people and keep them in our community, and that they want to come back if they have the situation occur again.
That's awesome.
The outcome measures, we measure our discharges to home, and as well as that score, that functional scale I was telling you about, and also our patients' experiences. You know, we try to survey them to see what can we do better, what can we improve upon each time that we have somebody.
Is this one of those programs where you sort of, obviously the two of you are living it every day, so you see it. Is it one of those programs that you envision continuing to grow and to become a bigger part of the care process from start to finish, not just in hospitals, but sort of broadly overall, keeping people, helping them recover and get back to where they were before they came in?
Ultimately, that's our goal, is to just keep it growing, and not just there, but all our sites, because it's such a great service. When someone has a major event that Geneva General or Soldiers and Sailors can't handle, the ED, they get transferred up to Rochester, and if they need short-term rehab up there or IV antibiotics, all that, they kind of want to keep them up there, those facilities. But it's so great to know that they can come back to their own community and receive these services. So it's not a hardship for the family to go visit, right? Mm-hmm. That's a big trip up there, and this way they can have it right in their own backyard, that great care, have those successful outcomes. And so if we can continue to grow it and be here for years to come for our community, that would be awesome.
I think that's a big part of their success too, is to be able to have their family close by, and we can also integrate them into the therapy sessions. If they're going to be the ones assisting at home, we can build them into the session to teach them, the proper way to move them, or to keep themselves safe while they're assisting them.
People think the rehab team are us, the clinicians, but it really is the patient, their family, and us working together, with the providers to just really optimize their mobility.
A real team effort. Curious minds probably would like to know, how can they learn more about a program like this, beyond obviously listening to a conversation like this one? Does the hospital have any resources right now online, Finger Lakes Health, to be able to learn more about this program?
Indeed. We have some rack cards that are throughout our facilities, as well as a bifold brochure that we have at our primary care offices, and then they do have a piece on the Finger Lakes Health website.
Sweet. And we will link to that in the show description and on the story on fingerlakes1.com. Ladies, thank you both for coming in today. Really appreciate the time, for sure.
Thanks for having us.
Before we go, a quick reminder that new episodes are released every week on fingerlakes1.com, Spotify, Apple Podcasts, and Anchor. You can visit insidetheflx.com for past episodes or to leave us a voice message. You can also drop us a line by emailing insidetheflx@fingerlakes1.com. Subscribe to the show wherever you are listening and become a Patreon supporter if you can. Visit www.patreon.com/FL1 to learn more. Links to all of those things are available in the show notes below. Thanks again for listening, and I will see you next time.